Bunları artık istemeyelim, yani müzik oluyor. Hi. As I was preparing my speech, Hassan we decided that Hassan would focus on the Turkish case and I was going to talk about what happens in the world. And I will talk about the 5-year period from 1999 to 2004, how we prescribe psychotropic drugs. I'll make a comparison and try to discuss our position in prescribing behavior. Looking at the prescribing behavior of psychotropic drugs, we see that in 1988 there was a huge tendency to prescribe SSRIs with the use of atypicals and second generation antipsychotics in 1990s. There was a tendency towards prescribing those, and then there were some large-scale trials like Katie or STEP, studies on bipolars, about clinical, practical practices. Those also had an effect on prescription behavior. And of course there were some tendencies to make pharmacoeconomics and pharmacogenetic studies, especially after the year 2000, and cost-effectiveness analysis took place. I talked about some large clinical trials, and I know that there will be a detailed overview of these clinical trials, but these are trials conducted by either pharmaceutical companies. They are different from those sponsored by pharmaceutical companies. I'd like to correct myself. And they're different in that they're not the effectiveness studies of the drug companies. In these studies, we realize that there are changes according to the patient, where it's prescribed and how it's prescribed. I will talk about antipsychotics between 1950 and 1990s. We see that after the 1950s there's an increase, between 1970 to 80 decrease, and after 1980s a rapid reduction in the use of antipsychotics. There are some long-term side effects like tardive dyskinesia, which we came to understood, and then written consent was another important arrangement. Then we showed the emergence of SSRIs, which points to a shrinkage in the antipsychotics. Coming to 1990s, we see atypical antipsychotics. This study is from 1989 to 1997. Of 1,600 rounds, 728 resulted in prescribing antipsychotics in 1989. In fact, the typical antipsychotics are prescribed in the same way. Atypicals are prescribed in an increasing manner. In this case, you tend to ask whether there's another indication for atypicals. And we see that antipsychotics are prescribed at similar percentages in the two reference years, 1989 and 1997, where in 1997 prescription was 88%, and atypical antipsychotics increased the prescribing behaviors. But this is not true for all studies, because it differs from country to country, from region to region. and different ethnic groups, and we realized that there could be some increase in prescribing antipsychotics because of, for example, insomnia. Coming to the years 1996 and 2006, there are new atypicals. What draws our attention is that olanzapine use reached its summit with 32%, but with the new atypicals, there is a significant reduction down to 19%. Another important point is in the treatment of schizophrenia, mood stabilizers are not extensively recommended by the guidelines. However, this is the rate of their use. Between 1994 and 1998, a study was conducted, and in 1998 they make a comparison between schizoaffective and bipolar patients. We see here that valproate use rose from 12 to 35% in schizophrenia, so there's a threefold increase. Looking at lithium, we see it dropped from 13.2 to 11.3. So as you're using a mood stabilizer, you're reducing on lithium, but valproate is threefold more. And for others, there are similar tendencies. Looking at schizoaffective disorder or bipolar, we see the rates are almost similar. For bipolar, in 1998, valproate is prescribed twice as much as lithium. Looking now at other countries, there's a fourfold increase this time in the use of atypicals. There is the REHAB study, a little bit different from Turkey, Europe, and US. This REAP study was conducted in 6 southeastern countries. 71.9% of all prescribed antipsychotics are typical antipsychotics according to the REAP study. Of course, there comes into play the healthcare policies and the prescription behaviors of the physicians, the prescription tendencies. 53% is the total percentage of single antipsychotics, and 2 antipsychotics or more are prescribed by 25.8%. There are certain things to be drawn from here. For example, clozapine is prescribed as the most favorite atypical, and the reason is the others have lots of generics, but in China that's the most favorite. In Taiwan, the utilization rates are very low, atypicals, because of the healthcare regulations. And in Japan, we see multiple antipsychotics used at very high amounts, and that is again something to do with the healthcare policies. Multiple antipsychotic use is an issue in the world. It ranges from 10 to 60%. These are the data of our clinic. In 2004, atypical antipsychotics increased to 54.4%. 2 or more antipsychotics were prescribed from 11.6 to 20%. Now, there are some, as you see, differences in tendencies of prescription. It's supposed to be declining by years. However, there's an increase in the prescription of 2 or more antipsychotics. Usually, there's a complaint of lack of efficacy or insufficient efficacy. So the reason why there's multiple antipsychotics here is, besides lack of experience, lack of efficacy. Here is a study of our clinic between 1994 and 2004. Here are typical and atypicals prescribed. Only in the Asian countries are atypicals are combined with typicals. Another point is adherence or compliance and quality of life. In our clinic, the type of the drug does not make a difference on compliance or quality of life. I mean, there is an increase between 1999 and 2004, but that doesn't have anything to do with the type of drug. Let's now take a look at the mood stabilizers, and then we will discuss our clinical data. Here, the clinician's opinion is that the newly developed drugs have less efficacy than what they claim in their application to the FDA. There are two studies conducted between 2000 and 2004. Lithium is prescribed at lower doses, and antipsychotics are twice as much prescribed. Here's another study with 7,760 patients between years 2002 and 2003. 50% is antidepressives. Usually, patients who refer to psychiatric clinics are prescribed 25% of mood stabilizers, though it should be just the other way around. Atypicals and antipsychotics are 11%, and at the end of the first year, we see 44% of the patients receiving monotherapy only. The rest are administered combination therapies. In bipolar 1 and 2, we see antidepressives taking the first place. That's quite different from our clinical practice. Another study is the STEP-BD study on NIH, an example to the practical clinical trials. The purpose is to see how the clinical applications are of their current treatment methods. At first, we see antidepressants. Only 11% are receiving mood stabilizers. Lithiums are even at lower rates. Antidepressant use is higher in US. However, in European studies, we see the rates ranging between 10 to 20%. In our clinic, we scanned 1,200 patients, and 40% in 1999 we prescribed antipsychotics. In 2004, with the atypicals getting the indication, the rate goes up to 91.2%. Combination rate is also very high. More than we see that 37% of the patients do not use a mood stabilizer, 67% do. SSRIs I prescribed at higher rates, and we see that over the years there's a rising tendency, and sometimes leaps that are difficult to describe. The same happens in Italy. Between 2003 and 2004, there's a 20% increase of antidepressives, and the discussions are based on the national Italian study. 41.5% are giving the diagnosis of neurotic disorder, so it's not in the indication. But in the next trial, they say it's both depression and anxiety disorder and not neurotic disorders. I work with young people and children. As you know, antidepressives were said to increase suicidal tendencies in children. So there was a warning issued by the FDA in 2003. So there is a drop in the prescription of antidepressives, and after that we see an increase in this age group in some countries in Europe. Looking now at anxiolytics, they are not used for short times at small doses. They're used for long times. In some countries, it's used against side effects by 30% in schizophrenic patient groups. Let's now talk about the effect of clinical trials on our prescribing behavior. We use the data from the efficacy and effectiveness studies, but the clinical practices may be quite different from that. So we need very large-scale, practical clinical studies with very big samples, representative samples. Thank you. Thank you very much.